Okay, it looks like it's time for us to get started. Hello, everyone, and welcome to this month's Northwest ATTC webinar. I am Jennifer Verbeck, and I'm your host for today. We're excited to have Dr. Sara Smucker Barnwell presenting for us. Before we get started, I want to let everyone know that here at the ATTC, we believe that language matters and words have power. We strive to be culturally informed and inclusive, and we really value your feedback on how we're doing. Please email us at northwest@attcnetwork.org if you have any comments or suggestions for us. A couple of quick housekeeping things. First, if you have any questions for Sara during the presentation, please type them into the chat box at any time. After she's done speaking, David Jefferson, our new Director of Training and Technical Assistance, will compile and read those to her. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. So please take that survey. It helps us bring the content that you're most interested in. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of this webinar, and that should be available later this afternoon. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance, and that takes us about a week to get those out. You don't need to do anything to get the certificate unless you're watching this in a group. In that case, please have someone in the group email us within a business day with the names and email addresses for everyone who wants a certificate. And again, our website is up there on the screen. It's northwest@attcnetwork.org. Okay, and then now on to the webinar. As mentioned earlier, today's speaker is Dr. Sara Smucker Barnwell, who is a licensed clinical psychologist who provides evidence-based psychotherapy and consultation in the greater Seattle and Eastside areas. Her research and publication interests focus on ethical intersection of technology and evidence-based therapies. Dr. Smucker Barnwell is a partner of Seattle Psychology, PLLC, and she is also the former director of telehealth training and education for the VA Puget Sound healthcare system. And with that, I'd like to welcome Sara.
Thank you so much, Jen, and thank you so much to Northwest ATTC for having me today. I'm delighted to be here to speak about telemental health fundamentals. We're going to be talking a bit today about how to prepare your office for telemental health and how to engage those clients that you see through this modality. And Jen, I don't seem to have control.
Sara, you need to click on the slide to take control and then try advancing, but I may take it back when I mute myself again, so you might have to do it again. Hold on one second.
Thanks so much. I appreciate it. Okay, so today we're going to talk about a diversity of themes. We're going to endeavor to talk about the telemental health fundamentals. This is a pretty broad and diverse subject area, so the goal today will be to speak about the building blocks. At the end of the talk today, we'll provide some information regarding an upcoming learning series. So if you're interested in doing a deeper dive on any of these themes, there'll be information about how to get more into the finely sort of honed details of implementation. You know, of course, when we're speaking about telemental health, the conversation we're having today is dramatically different from the one we would have had just 6 months ago. The novel coronavirus that causes COVID-19 has brought telemental health into the forefront for many of our practices. And indeed, 6 months ago, we might have been discussing these themes in the context of something that would be interesting to try, something you might like for a specific client. Now, instead, for many of us, this is something we may be required to do, or something that is the only option for us to deliver care that is safe for our clients, safe for ourselves, safe for the public health. So I really want to talk a little bit today about the context in which this occurs. And of course, we want to spend some time speaking about what it is to engage clients through this modality, particularly if this is not a modality that is familiar to us or something that is in our lives as we handle our personal communication or our collegial communication. So let's start off with some operational definitions. Telemental health refers to the provision of any mental health services that uses telecommunication technology. I find this definition to be broad to the point of almost meaninglessness. It's handy, but it really could be any mental health service that we deliver, via video conferencing or telephone, or perhaps via email or via secure messaging. All of these would be valid modalities for telemental health, very diverse technologies that underlie this milieu. For today's purposes, we're really going to be speaking about telephone and video conferencing based care. So how we can see clients, remotely and securely in a way that is still conducive to really high quality mental health care. And, I will say, honestly, when people say telemental health, often they actually refer to video conferencing, and that's really what they're talking about. Though I think telephone's sort of our unsung hero, so I always like to make sure we include it. Again, telemental health emerges right now as a potential tool in the public health crisis that we are living through. Obviously, this is one opportunity to facilitate social distance and allow us to continue our clients' care without disruption. But I want to acknowledge that for some, telehealth may be the only option. I want to, sort of acknowledge that for many of us, mental health services falls under the rubric of essential services as defined by the state of Washington. So we may have the option to see our clients in person, and I certainly don't seek to invalidate or marginalize that choice. However, for many of us, we are also choosing to either bring telemental health in a portion of our practice or perhaps the entirety of our practice. So right now, whereas telemental health 6 months ago was kind of this interesting option, some people may have elected to look into it. Again, it's really been brought much more to the forefront of our attention, and for some of us, a stark necessity. So we want to think a little bit about how to prepare both for you and for the client. And the old adage that the best offense is a good defense seems really relevant. Spending some time being thoughtful about how we're going to prepare in advance of that first telemental health client can really pay dividends. So first and foremost, we want to think about the availability of technology and physical space. We're going to dig down into this a little bit more later in the talk, but we want to think about what kind of hardware and software would I need, and do I have a space that's conducive to this? Many of us may be continuing to use our professional offices and are able to deliver telemental health care from there. Some of us may be electing to use a home office, and we'll talk about some of the specific challenges there. But first thinking through, do I have the necessary equipment? So do I have a telephone or a mobile device I could make a call from? Do I have a video camera? Do I have a computer that is reliable and is updated enough that it can run video conferencing software? The demands are pretty minimal, but worthy of consideration. And then we want to think through, what services are we going to offer? And again, I want to acknowledge this is a really different conversation than it was 6 months ago. Very frequently, when I'm speaking with folks, they would say, well, I would prefer to start off offering services that are what I deliver, most often, or perhaps are the least likely to have emergent concerns in my practices. So not uncommonly, folks might say something like, I'm going to start off delivering telemental health care with my clients where we're working on relapse prevention. Perhaps they have some, good time of sobriety under their belt. I'm not concerned about the need for hospitalization. We're not doing UAs. We're not doing breathalyzers in session. Again, that was 6 months ago. And these days, for some of us, this may be the only way we're delivering care. So for some of us, we may be delivering all the usual services that we deliver through care as usual. But I always want to reinforce the idea that, we don't have to deliver a service we're not comfortable delivering. And in thinking through what cases we're comfortable seeing, what cases we're not, particularly if we're just getting started. Maybe I start off with those cases as I'm getting my legs under me and really getting familiar with the technology and the implementation of telemental health. Perhaps I start off with those cases that feel most familiar to me, and I branch out to those other cases that are more challenging to me as I progress. So we're thinking through what technologies we're going to use, what services we are going to offer, and how we're going to approach that. Some of our clients may be very adept at video conferencing. This is something they do in their everyday lives, very, very usual, and some may have never tried it previously. And a little bit later, we'll talk about some of the ways we can troubleshoot with these clients. But again, I really encourage providers to think about their boundaries in advance and really just reinforcing the message that, we have the autonomy and the permission to kind of figure out what feels right for our practice. I always like to highlight that I am not aware of any evidence-based contraindication for telemental health. That is to say, I've never seen a research study that says, never see this type of client through telemental health. I will acknowledge that there are some clients that I think are less served and better served through the modality. So for example, in my practice, if I have a client who has ideas of reference or delusions around recordings or technology or some sort of observation, video conferencing can be an exacerbating modality for them. And for that person, I would think more about the telephone. Or alternatively, when I've had clients who have a profound agoraphobia, that is, related to their substance use disorder, that would have been someone 6 months ago I would have thought twice about delivering telemental health for. But now, to be honest, I'm going to be, a bit more flexible on those boundaries. Many folks will say that they prefer not to see clients who have emergent concerns, concerns that the client needs hospitalization. I respect those boundaries, that my colleagues have. I will say that I see clients who may have thoughts regarding self-harm or may have a history of self-harm. I do see them through the modality. And I always like to remind us that, back in the day, our standard of care was telephone hotlines for clients experiencing suicidal ideation in between sessions. So again, these are the things we're going to think about beforehand. Are there any contraindications for your practice? What services are you going to offer and how are you going to offer them? It bears mentioning that, many of us are now working from a home office, which is great in some ways and challenging in other ways. I like to talk about my new coworker, my 9-year-old daughter, which, brings new and exciting challenges to protected health information. So, that PHI, we're still bound to those requirements of HIPAA that we were in our professional offices, in our home offices. So I like to think a little bit through, how we can safeguard that home office to make sure our telemental health meetings are a success. When we are engaged in video conferencing appointments, thinking about where we're going to host those appointments within the home, it might not be the time to sit in front of all the family photos or, all the concert posters that you're really proud of. Those would not necessarily be the background I would recommend because, those will inevitably be disclosing information to the client. Additionally, the busier the background, the more burden we place on that video conferencing call. So I really recommend that we find a nice, austere, boring chunk of wall in your home and to have your appointments there. As much as I can, I try to model sitting in a professional setting, making sure that I'm setting the tenor for the meeting. And we're going to talk a little bit more about this, how we can help clients to really remember the boundaries of this appointment, that this is still a healthcare appointment they're having, even though they may be having it in their home. We want to treat the hardware and software that we use for the meeting just like we would other, protected health information. We want to secure that and make sure that it is not sitting out. So if I have a video conferencing program that I'm seeing my client on open, on my computer, I wouldn't later then hand that same computer with all the software open and my medical chart open to my kiddo to play a game. Or if I have been speaking on the telephone, on my mobile device, with a client, I wouldn't necessarily then hand that phone for my kiddo to tinker around with because we would not want her to oversee the numbers, things like that. We want to be a little bit thoughtful. And just if you had a desktop computer in your office, you would lock that up at the end of the day. We want to secure the hardware that you're using to see clients. And so too, if you have software downloaded on a computer, you want to have your own distinct user profile protected with a password, protect those mobile devices with a password, and just think through those little extra securities that are, even more relevant in the home office where information could pretty easily be discovered by your new coworkers, that 9-year-old coworker you might have. If you have smart speakers in your home, I really encourage you to take those out of the space where you may have your telemental health appointment, because that Alexa, she's always listening. You know, occasionally Siri answers questions and I didn't even realize I asked her. So being a little bit thoughtful about any interactive devices you may have in your home. I also encourage folks, if you have the opportunity, to consider using headphones. It's one way to make sure that your client's voice will not be overheard, and I think increase the security and privacy and confidentiality of the call in a pretty low-tech way. So thinking through, do you need to make any changes to your schedule because of your needs or your client's needs? Again, especially in that home office, many of us may be trying to collaborate with a partner, you know, who's working from home. We may be providing care to a child or an adult in our life that needs care. Our schedules may have become much more complex, as may have the schedules of our clients. So again, you know, in the world of telemental health, we may have more flexibility, and we may be able to flex our schedules, you know, to meet the needs of our clients and to, you know, meet our own needs as well. I'll share that many of my clients are homeschooling kids, and I've definitely changed many time slots from my usual daytime appointments to some evening and weekend spots. Transparently, that is not my favorite thing I've done, and I look forward to the day when I can get my schedule a little bit more back to normal. But for some of my clients, this is the only way that they could meet all their obligations and, you know, have no disruption to care. And then finally, if you do have kiddos in your home, you know, thinking through how we can be attending to them and also making sure that we are, you know, maintaining the privacy and confidentiality. We can't have kiddos, you know, walking into an appointment. So too, you know, we can't be ignoring our children and allowing them to burn the house down. So, you know, finding that negotiation, is there a shift in schedule that will facilitate that? Or, you know, how will this best work for you? Okay, client location. I jokingly add this image of a bathtub because I will say in the last few months, and I'm guessing many of the folks on this call have as well, I've had some telemental health appointments in wacky locations, telephone and video calls in people's bathrooms, in closets, in cars, you know, and again, 6 months ago, if someone had said, gosh, I'd really like to do a telemental health appointment, you know, why don't we meet in my closet? I would have had some concerns and I would have said, I wonder if this is the best fit for that client. Acknowledging that it's possible I could have been talked into it. I am sort of an unabashed telehealth evangelist. So, you know, but that being said, I don't think it's ideal, but I think we're trying to be flexible. But above all, we want to help the client find that private, confidential space. Many of us who have done telemental health over the years have some sort of anecdote about, you know, a spouse or someone walking through in the background, perhaps in their bathrobe, perhaps how they didn't want to be seen, you know, and so we really want to help clients understand through our informed consent process, you know, what our expectations are going to be. And I really like to let folks know that I expect them to try to find a private space in their home where they cannot be overheard, where they'll be alone, and, you know, that this is going to be a healthcare meeting. So, you know, if they met me in their pajamas in bed, you know, I would encourage them, let's find a place where you can sit down. Also, honestly, if you're on somebody's knees for the entire telemental health appointment, it may leave you slightly nauseated. I try to embed these expectations in my informed consent documentation. I actually put them in the automated reminders that they receive through my electronic medical record, or EMR. For the young clients I see, I'll often recruit the help of their parents. You know, can you help me find your child a place that would be appropriate to meet, someplace that's going to be private from their other siblings, you know, someplace that they will have the ability not to be overheard, and someplace they can be seated and really help them understand that their attention is to be with the appointment. I always check in at the session's beginning to check in where the client is, to make sure that they're alone in the space and cannot be overheard. You know, I check also that they can hear and see me very transparently. The last few weeks, I've had a few interactions where I think I'm talking to someone, but indeed they've muted me and they're on another tab and they're answering emails. So, you know, starting each session, making sure that they're in that secure space and they're ready to go. Okay, I've mentioned documentation a few times, And, these are the types of documentations I think that differ slightly when we're doing telemental health. I always encourage folks to get a distinct informed consent for telemental health that reviews the risks and benefits of the modality. The risks, anytime we put something on the internet, we do have increased risk to information security. The benefits in this context are pretty straightforward. We're using this as a tool to help flatten the curve of the coronavirus and protect our clients' health, our health, the health of the public. If you have an existing client that you are transitioning to telemental health versus a new client you're conducting an intake with, I still recommend getting that informed consent. Either in that informed consent or as a distinct document, I encourage folks to get an emergency plan. And this doesn't need to be fancy, truly. This can be several sentences, but basically, communicating a plan with your client as to what you would do if something emergent occurred remotely. So let's say my client has a medical emergency. If they were in my office, I would call 911, I would wait with them, and I would make sure they got the help they needed. If they had a psychiatric emergency, I would be doing an assessment and triaging to what I thought the next best step would be for their care. So too, remotely, we're thinking these things through. So, usually I just do a few sentences saying, I understand that you're going to be at this address location. This is a telephone number I could call if I'm doing a video conferencing appointment. Perhaps if I'm doing a telephone appointment, I'm going to get an alternate number should there be a technology disruption of some kind. If possible, I like to see if there is someone else in the home, who might be able to be boots on the ground support. If they're having a medical emergency, is there a spouse who's aware they're in therapy at home? Is there someone who could help? And then, on the sort of less emergent side, if there's a technology disruption, is there someone who could help them get things back on track, particularly if my client isn't the person in the household who most often handles the technology. So in doing this, these are two sort of separate ways we think about the documentation for telemental health. And I want to acknowledge, exchanging documents can be really challenging at a distance. It happens to be the case, and we'll talk about this in a bit, that the Office of Civil Rights and the U.S. Department of Health and Human Services recently told us that we have a little bit more permission to exchange information. So, they're telling us that we're able to use non-public facing video conferencing products like Skype and FaceTime. It's still my recommendation we use one designed for healthcare. We'll talk about that shortly. But we can email things a little bit more. So it can be something sort of inelegant. We can use email. We can use post and simply have our client mail documents to our clients, have it mail them back. We can use the fax. We can, if you have an electronic medical record that has an integrated secure transfer for files, that's great. Use that. But I just want to highlight that whether we're exchanging informed consent, emergency plans, or homework, it needn't be a high-tech solution. Low-tech solutions work great as well. And finally, if we're just not able to get these documents, if it's just not going to happen, it is just not an option, going over these things verbally, the informed consent, the emergency plan, homework expectations, and documenting them in our chart offer another really viable way, to help manage our risk and prepare for our telemental health sessions. Okay. I'm going to introduce you now to my long-suffering family who have made many demonstration videos with me. So, be gentle. Hi, Jason.
Hey, Dr. Sara.
Well, thank you so much for meeting me via video conferencing today. I know we usually meet each week in my office, but in light of everything that's going on in the world, we discuss the risks and benefits of transitioning our meetings to video conferencing to help protect your health. I know you have a family member who is in a high-risk category, as well as my health and the public's health. So thank you. Thank you for being here.
No, thank you.
Well, Jason, today I'm seeing just about half of you. Would you mind taking a step, I believe would be to your left?
Oh, yeah, sorry. These technology. Oh, hey, look at that.
Well, that is awesome. Is that NASA?
Yeah, it is. Isn't that cool?
It is super cool. Today, just so that I can see you and just enjoy, interacting just the two of us, if it's all right, like the information I had put in our informed consent, I'm going to try to keep our background as austere as possible, just the room as it is. So if you wouldn't mind, awesome.
Yeah, you did it. That makes sense. Yeah.
And thank you for doing the online consent form. I really appreciate your taking the time.
Sure.
Did you have any questions from the document that were outstanding to you? If not, I'm just going to go over a few of the basics.
No, but why don't you go over the basics again? Just, yeah, that'd be great.
I'll hold forth. Okay. So, we talked a little bit about the risks and benefits. Of course, the benefits being that it is protection for our health. The risks, anytime we put information on the internet, there is an increased risk. There have been prominent cases in the news recently of people's video conferencing calls being intercepted. That being said, I do use a product that is compliant with HIPAA, that federal regulation that protects our health and safety. Additionally, this is just a product designed for healthcare. So it has some additional securities, but I want to acknowledge nothing is foolproof. So anytime we put information on the internet, we're taking a calculated risk, and make sure that you're still aware of that.
Okay, yeah, that makes sense.
Okay. The other thing that was really outlined in that informed consent document related to privacy and confidentiality. So, I want to confirm, consistent with the expectations we talked about in advance, that, you are alone in this room and cannot be overheard.
Yes. I think that should.
Oh. Well, it sort of seems like there might be someone in the room with you.
Yeah. Oh, hey, sweetie. Well, this probably isn't the best time.
Okay.
Thank you. Would you mind closing the door?
Sure.
Thank you. Yeah.
Fantastic.
Okay.
Thank you. So we'll try to conduct our meetings, alone in a private space where we can't be overheard, so we can just have that confidence and confidentiality and privacy that we do typically in my office setting. So
That makes sense.
the final thing that was outlined in that informed consent document talked about emergencies. So just I want to make sure that you know what's going to happen in case of an emergency.
I presume you would just come over here and help.
Well, that would be good if the world worked this way. Unfortunately, I'd like to get you a better, higher quality type of help. If you needed emergent help, my response would be to contact emergency services and direct them to your home. I thank you for completing the release of information that would allow me to contact your spouse, who I suspect is very lovely and smart and a kind person. We would contact that person to come help you, and thank you for completing the ROI so I could get her to be boots on the ground help in a situation that would be safe for her to help. So if you fall over and break your toe, she can open the door for the emergent services that I would send to your home.
Yeah, that probably does make a lot more sense. Okay. Well, that all sounds good. Thank you.
Well, you're very welcome. All right, Jason, let's get started and have our session today.
Fabulous.
My spouse asked me if I would ever actually send emergency services for a broken toe, and I reassured him no, I would not. Okay. So just, a sort of lighthearted example of some of the themes we might review at the initiation of a first telemental health session. Probably the question I most often receive is, which video platform should I use? And again, we had this recent announcement from the federal government saying, hey, go ahead, use Skype, use FaceTime, use Zoom, anything that's non-public facing. So they're saying, don't use FaceTime Live, don't use Instagram TV. We shouldn't broadcast our sessions to the adoring public. But, these other products that are, very available and easy to use are okay. And I think that's great. And I want to acknowledge, in a pinch, if that is what we have available, we should use it. However, I also want to acknowledge that if I had a board complaint, if somebody was grumpy with me and complained about my use of this, they would do so to my state regulatory board. It would not be to the federal government. And my state regulatory board for psychology, anyway, still advises me to use a product designed for healthcare for video conferencing. And this is the advice I usually give folks too. A product designed for healthcare will offer us what's called a Business Associates Agreement. You'll often see it abbreviated as a BAA. And this is a document that says, hey, I am aware of the constraints of HIPAA. I'm going to be a partner in this, and I'm going to facilitate making sure that we hold your meetings to these standards. A product like Skype is a great example. It's a really great product, great usability. However, the manner in which Microsoft oversees quality control is by looking at snippets of calls. Now, I don't think they're doing this to insidiously collect our data, but I believe they're doing this to check to see if there's lag or is there pixelation or, how does that call look? But in doing so, that would be contrary to what HIPAA tells us to do. So it's some of these themes, that I think you just get from those products that are designed for healthcare. We want to find a product that's pretty user-friendly, something that's cost-effective. Now, some of us may use an electronic medical record. I, for example, use a product called Simple Practice. It's my EMR, and it has an integrated video feature, and lots of them these days do. Those are great, and typically they're pretty inexpensive. I think mine's $10 a month, and it's already a tool that I'm familiar with. If, however, you don't use an EMR or the one that you use does not have this feature, that's just fine too. I'll mention one company that I think does a nice job called Doxy.me, DOXY.me. And this is a product that is free. It is designed for healthcare, and effectively, it's pretty darn simple and easy to use. It's a waiting room and a treatment room for video conferencing appointments. So if you're thinking about adding video conferencing to your practice and haven't done so previously, I would check out Doxy.me or check out something that's integrated into an EMR if you have one. I also want to acknowledge as soon as I give advice on any video conferencing product, 2 weeks later it changes. So it's always worthwhile to check in on what your colleagues are using. Okay. So let's talk a little bit about engaging the client, in clinical care. Once we've prepared for our telemental health appointment, we have the client, either an existing client we're transitioning or a new client we're bringing on. If someone is unfamiliar with care at a distance, I like to offer them a 5-minute sort of test call. Perhaps it's a video conferencing call or a telephone call. And in doing so, it gives them kind of an opportunity to try out the modality before we really dive into the clinical issues. It does take time out of my schedule, and that's a little bit extra, but I think it's a nice opportunity to acclimate the client, get them used to it, and really help them feel comfortable. When we do calls over video conferencing in particular, there are some specific concerns regarding our body positioning and our gaze. A wacky reality is when I look directly into my camera is when I appear to be looking into the eyes of my client. However, if I look directly into my camera, I'm not going to see my client all that well because they're probably lower on the screen somewhere, juxtaposed next to that camera. It's not going to be exactly the same space. So it's quite common that during a video conferencing call, eyes may appear slightly cast downward. So I always like to bring that to the attention of my client. I try to back up off the camera a little bit so they don't just see my large looming head. They can see a little bit more of me, because there's reality is you lose some information, some of that good clinical engagement that happens in your office. If a client tells me something really sensitive, I have a tendency to lean in. It's just a human response. And that's probably not going to get picked up on video conferencing. I had a colleague tell me just this week that their client had a relapse and they were really struggling and they had become tearful. And they mentioned it. They said, "Oh, I'm really sad about this. That's why I'm crying." And my colleague said, "I didn't even realize, with the video conferencing, they hadn't even seen, the tear was so small, they couldn't see it." So I think there is a reality that we are losing some data here. So, we want to slow the pace down and we want to collect as much information as we can. I really like to collect as many surveys as I can in advance when I'm doing telemental health. Now, I happen to have an electronic medical record that makes that pretty easy. Many people will elect to read surveys over the video conferencing call. I think that's great. I do wonder if it changes the outcomes. If I'm giving a MAST and if I'm giving the Michigan alcohol screening test to someone and they're filling it out by hand versus verbally reporting, I do wonder how that impacts things. But, I'm doing my best and getting the information I can. But above all, I just want to, encourage us to slow our pace and collect as much information that we can and not make as many assumptions. Because there's this reality that we are missing information. We're gaining some things. I get to see people's homes. I get to have a better understanding of their context. But I'm going to miss if they have alcohol in their breath. I'm going to miss if they have an unsteady gait. I may, if they're looking away or they're looking elsewhere in an in-person session, I would have some assumptions about that. I would wonder if they were feeling uncomfortable, if they didn't want to be here today, or just something was going on. Honestly, in a video conferencing session, if I see them looking away or averting their eyes, I'm wondering all of those things. I'm also wondering if they're checking their phone or perhaps catching an email that they've been waiting for work. seeing if their children have burned down the house, all those usual things. I think it's just an added layer of complexity. I also want to acknowledge that for many of us right now, the client may be uncertain about telehealth. And for me, this is really a brave new world. Again, 6 months ago, if a client didn't want to have telehealth, I wouldn't even know what we were talking about. I would sort of say, gosh, this is not appropriate for this client. We should be really respectful of their boundaries and giving them the care that feels best for them. Now, however, it may not be an option to give them care in another way. So I think, I really just want to say I want to validate my clients' feelings about the modality, perhaps my own feelings about the modality. We're all doing the best we can. And so I think it's one of these things where we go slow, we acknowledge we're probably going to miss some things, we're going to gain some things too, but, we just do our best. And I'll be honest, I find clients to be very generous in this way. I have found the clients I see who I've transitioned from in-person to telehealth, that I'm wondering if others have too, I have found them to be very gracious and very kind, and they really know that, we're all kind of finding our way here. Okay, I wanted to bring your attention to this really wonderful substance abuse and mental health service administration tool that is available on their website. It's SAMHSAgov. It's in tiny little print there, but it's just SAMHSAgov. And this is technology-based therapeutic tools in behavioral health services. And they have some really nice overviews on telemental health specific to SUD. Again, this has been a controversial one. And, not infrequently in the past, folks have said to me, gosh, I'm not really comfortable delivering SUD care over telehealth. It wouldn't be my first choice. It's a little bit riskier feeling to me. And again, I really want to acknowledge that. And it's something I have done historically, and I've been comfortable doing with historically. And for many of us, that may be shifting because it may be the only way our clients are accessing care. And I want to acknowledge there are some realities that we are not going to assess use as well. I'm not going to be able to send them to the UA lab, down the hall. I'm not going to be able to breathalyze someone in my office. Transparently, I don't really do that too much in my office these days anyway, but there have been times in my career I have. I think it's a little harder to gauge client intoxication if that's something that sometimes happens in your practice. I've had some folks say, well, gosh, if I have a client that is in a period of active use and they're really ambivalent about stopping right now, I don't really love them driving to my office. So telehealth may be a way that helps protect them and protect the public, from potential harm of them driving while intoxicated. But I think what we're going to see is this really unprecedented rollout of SUD services over telehealth. I'm honestly sort of excited about the research and validation that's going to come out of this to help give us more tools and give us more data to work with. Perhaps the greatest concerns that folks will cite, are emergencies. So, what's going to happen if something emergent occurs remotely? And again, we've tried to document a plan. It doesn't need to be a fancy one. A simple one will do via that informed consent process. Generally speaking, it's pretty straightforward. If my client is having a medical emergency or a psychiatric emergency, I'm contacting 911. If they happen to live in an area that I know has a mental health professionals team or an SUD team that is distinct from the 911 line, I try to research that and have that available in my community. Again, if there's someone in their life that can be boots on the ground help, a support person in their life, I like to capture a release of information in advance and ensure that it would be appropriate to contact that person, assuming they are a safe, appropriate person to help, and assuming the situation is safe to bring another person into. One last thing, I want to note that risk assessment in the era of coronavirus is a different thing. I think we have different thresholds for seeking care. Of course, if I think someone is at imminent risk for harm, my recommendation still would be to have them have a hospital-based assessment. But I think we're contending with this new consideration, which is how comfortable is our client going to an ER? No one's ever terribly comfortable going, but now it's something different. How comfortable are we sending folks to the ER? Again, in my practice, it's still something that I will do, but I definitely am thinking about it further. Okay, a few hacks. Here are the various mistakes I've made in my career, and I will share them with you. And, that maybe you've made them too, and maybe you never have, in which case, good on you. When you are having a telemental health appointment, want to do your best to silence the environment. So by that, I mean close those other tabs or windows on your computer. If you have a watch or, a phone or something that beeps and boops, closing those. If you have notifications set up on your computer that chime in, silencing those. I like to always have the patient's phone number available and ready. This is good for several reasons. One, if there was an emergency, this would allow me to contact them. But also, if I'm having a problem with a video conferencing appointment, it allows me to mute the audio on the video conferencing call and just have the audio portion of the call over the telephone. It's a bit of a strange thing, having half the call on the telephone, half the call on the video conferencing, but typically it will reduce the burden on the bandwidth of the call, so the video will actually improve and it will result in a steadier, more audible audio stream. And this is also very helpful if we're just having a slow internet day. There's a lot of demands on our bandwidth right now. Consider whether or not you want to research more than one video conferencing platform. I mentioned Doxy.me. There are lots of great ones. Many of them do have a small fee, but VC, spelled VSEE, VidYO, spelled VIDYO. There are many out there in the marketplace, but I think knowing more than one, or again, we could, if our healthcare product fails and we need to, we can go on Zoom now, we can go on FaceTime now, we can go on Skype now, but just having a little bit of redundancy there, just in case one of them does break down, because these are products that are really under unprecedented demand right now. Thinking a little bit about internet redundancy, if my internet goes out, I had this happen yesterday where they were servicing my neighborhood and there was no internet. So for me, I was able to use my mobile device. I happen to have what's called a personal hotspot, and many of our mobile phones, our iPads, anything we pay for a data plan for may have what's called a personal hotspot that allows us to tether or connect our computer as an alternate source of internet. Check with your carrier, your mobile carrier always, because it can be very expensive. It can really run up your data bill, but in a pinch, it's nice to have a backup. And then my final hack I would offer has to do with body, gaze, and hands. I am a terrible hand talker. I almost cannot speak without moving my hands. And it's something I really have to watch because it can be rather distracting to be flashing my hands around in front of the camera. I try to back up off my camera so folks can see those little motions. And honestly, I do every once in a while try to stare right into the camera, so that I can communicate that I really am looking at my client. When we talk about interjurisdictional practice, this is a big topic and something we'll really dive into in that learning series, but the things I really want folks to know is this pertains to the theme of practicing within your licensure jurisdiction. For me, that's the state of Washington. That's where I'm licensed. And historically, we try to remain within the jurisdictional bounds of those licenses. So I see clients in the state of Washington, so they have to be in Washington. And yes, there are loopholes and provisions and workarounds. There are lots of, this is changing. We had a federal announcement. The Vice President Pence had indicated that there may be some changes, some relaxation of boundaries for telemedicine. But again, at the end of the day, this is a state's issue and something that states are allowing us to do or not. If you are a psychologist, I encourage you to check the ASPPB, the Association of Association of State and Provincial Psychology Boards websites. They have done a very nice job of giving overviews of every state's rules regarding jurisdiction in the time of coronavirus. Other licensure boards will have similar resources. Generally speaking, though, as a good rule of thumb, we try to stick within the licensure jurisdiction where we have our license. And one of the final topics I want to talk about today is how to collect those payments remotely. And again, it doesn't need to be a fancy solution. If clients typically hand us a check, we can absolutely send out an invoice at the end of the month by mail and have folks send us in a check. It can work that simply. Others may have some integrated payment service in their electronic medical record, or they may use something like PayPal, or they may use something like Chase Pay. These are all great options. I want to acknowledge HIPAA allows us to use any of these payment services, but we just want to think through, how am I going to collect that payment? I have listed here in the slides the billing codes that we use for video conferencing, and I'm going to give you a very weird message on this. There have been so many changes recently. Here in the state of Washington, we've had executive orders that require reimbursement at the same rate for telehealth as for in-person health. That's great. And in 2018 in Washington, we actually had legislation that requires all telehealth to be covered. Also great. It has made for a wacky time for the insurance companies. So technically speaking, when we are billing, these are the service codes we would use. A place of service code 02 in our CMS 1500 billing form, so in that standard HIPAA billing form, Our place of service code would be 02, and our modifier code would be 95. And if this makes no sense, not to worry. But generally speaking, if you are someone who deals with billing and these, these words make sense, I would say call the insurer, because while I've given you the most updated information and put in parentheses the old way of doing it pre-2018, I will share with you that with all these executive orders and changes, insurers are confused. So I can tell you I have to bill it 3 different ways for 3 different insurances that I work with here in Washington. So I really say, gosh, if there's an insurance you work a lot with and you're transitioning to telemental health, it is probably worth your time, even though we all know it's going to be more than 5 minutes, to call that insurer and to really double check how they would like these appointments billed. Though, for your information, I've put the most up-to-date billing codes here on this slide. Okay. So, we have coming up this learning series. These will be a series of 6 meetings starting May 12th and meeting every Tuesday from 5 to 7 p.m. And we're going to dig into different topics. We have them listed here. If you're interested in participating, you can register at the Northwest ATTC website, and I'll be the one overseeing the series. So I hope to have a chance to dig into some of these themes more. We've covered a lot today, and we've done so quickly. So if there's more that you'd like to talk about, please drop in for one of these sessions. I want to thank you so much for having me here today. And here's a picture of me with my very first video conferencing unit. What a happy day it was. Thank you so much for having me. It's really been a pleasure. I think now we're going to have a little bit of time for questions and answers. And so I will hand the controls back on over to Northwest ATTC.
So Jennifer, am I taking over at this point?
Yep.
So Sara, we had a few questions come in, and there might be a few more that are coming. One person, Yun Chi, asked, what is the modifier code?
That's a great question. So so if you're familiar with the CMS 1500 form, there's a place of service code, and this code just lets us know where the care occurred. So if I was sitting in my office, the code is 11, and in the old school way of doing things, we would still have that 11 code for telehealth appointments. In 2018, they changed that to 02. If we go over, and I'm just thinking of, so again, it's going to look different. On the actual physical form, you would go over about 4 columns to the right, but if you're doing this through an electronic portal, this is neither here nor there. But the modifier code, typically there's, I think, A through D, you have an option to put several modifier codes on. This is where we put additional codes that indicate something extra about the appointment. So an example would be if you have an appointment that has clinical complexity, you can add a modifier code that indicates that. Sometimes you're reimbursed more for that. In the case of telehealth, it's this little additional code that we put in addition to the place of service code and the standard CPT codes. That is really like insider baseball, but I would encourage anybody, if you'd like a screen grab or something more, please feel free to email me and I'm happy to send that.
Okay. Here's another question from Gabriela Lule. Is Zoom video conferencing HIPAA compliant?
Great question. So Zoom offers several products. They offer different levels of service. The standard Zoom that you're going to sign up for and not pay for, or even the Pro Zoom that you pay, I have a Pro Zoom account, that you pay a more modest amount for, those are not HIPAA compliant, technically speaking. Now, if you wanted to pay for the HIPAA compliant Zoom, they do have a HIPAA compliant product. It's pretty darn expensive. I believe it's a couple $100 a month. It's a great one for enterprise level solutions. If you have a big company that needs a really big, hardy solution, I think it's a really good option. For the little guy, I recommend checking out some of the ones that are designed for healthcare. And I'll say, do I actually think there's any difference between the products? Not really. I think what you're really paying for is that BAA, that Business Associates Agreement. So again, we've had this announcement from the Office of DHHS that says we can use Zoom. And if it really gets down to it, and this is just too much to figure out, the healthcare products, I'd say we can use Zoom.
Okay. Here's a question from Elisa Jimenez. One of the clients always states that she's alone in a private space at home, but sometimes I see a shadow in the background. It might be her domestic violent partner, but she continues to deny anyone else is in the room.
Yes, this is such a hard issue. And I think DV cases, this is the issue that just really, I don't like telehealth for, and I see a lot of those clients in their cars. But I had a case once where someone was coming into my office and they actually had a phone in their bag, and they were having somebody on the phone, and this is hard, and I think this is one that I would try to have an honest conversation with my client as much as I could, acknowledging it may not be safe for them to have that conversation. So that might be someone I would transition to telephone with, if that gave them greater mobility. If they were on a telephone, would they be more able to be, not observed? Could they do that in the car? But it's a very hard case. I mean, they bring up just something that is really hard to know. So it's something I would ask about, but I too would be skeptical of the answers I was receiving. My client may not be safe to tell me what's happening.
Okay. Gary Pierce says, do we need a verbal consent or written consent to conduct telehealth counseling?
I think the highest standard, so I'll give you the answer that like the trust malpractice insurance risk managers have told me. The highest standard will be that written consent. So if you can figure a way, to get that written document, and I should mention a really nice free template for a telehealth informed consent document can be found on the trust. Their website, they're a malpractice insurance carrier. I think technically their full name is the American Insurance Trust. But if you just Googled the trust, they have a nice template. Simple Practice also has a nice free template. But if you just can't get one, and that's not going to happen, it is acceptable. The attorneys do tell me it is acceptable to simply go over it verbally and document in the chart that you did so. I think it's a nice thing to have that written document with a signature. I just had something come up this week where someone, wanted to use their records in a certain way that they had signed in their informed consent that they would not. And I really liked the fact that I had that signed document that I could say, oh gosh, well, remember, this is what we agreed to. So I think the highest standard is to get the physical document. But if you can't do it, then go over it verbally, document that you did so, and that should do it too.
Okay, thank you very much. Nikki Tennis, please tell us more about BAAs and how to do them remotely.
Sure. A BAA is a business associates agreement. And I think, gosh, if you want to Google BAA, this is something on a governmental website. There will be a standard template. That being said, it should not be your job to do the BAA. Very infrequently in my career have I ever offered a BAA, and that's been when I've been hiring an assistant or something like that. And this is where working with partner companies that are designed for healthcare is a boon, because a company that is cognizant of the concerns of healthcare providers will have a BAA to give you. So really, I mean, my feeling is our knowledge of it should go to the extent that we ask, do you have a BAA and can you send it to me? So if they have one, we're usually in pretty good, we're in pretty good shape, because there are some standard things that they have to agree to for it to be called a BAA. And mostly it's that they're aware of the HIPAA requirements to protect PHI, protected health information, and they're going to honor those and be good partners with us.
Okay, so here's may tug on your research capabilities.
Sure.
Is there research that compares the effectiveness of telehealth that includes video or just a phone call?
Yes. So there's, it's funny, the research for that is more robust probably about a decade ago. And I just haven't seen, I went to update something and it's sort of fallen off a little bit, but yes, there is. And so I'll chop it up a little bit. Pretty reliably in the research for telemental health video conferencing conditions, you'll find comparable outcomes. We still need more large RCTs, but there's some pretty good RCTs with some complex populations, looking at themes of anger management, post-traumatic stress, and others. Pretty comparable outcomes for telephone and in-person. When they have done comparisons, telephone, I misspoke. Video conferencing and in-person have the larger RCTs. When they have done comparisons of telephone, video conferencing, and in-person, outcomes, all good. Patient satisfaction, good. Slightly higher attrition in some of the studies I've read for the telephone conditions, and there was some question of whether you got something, for retention in seeing folks over the video conferencing. But when you look at telephone versus in-person, and I know there's quite a few studies that are CBT trials looking at telephone conditions and in-person conditions, again, very comparable outcomes in the treatment of depression and anxiety. So I think the research is there. The research on telephone versus video specifically is a little bit older, but what we pretty reliably find out across the conditions is that outcomes are good, patient satisfaction is good, and one of the things that always surprised me the most was that rapport, patients' reports of rapport was also good, because that would have been the area I would have thought would have suffered immediately and the most, but it doesn't seem to bear out in the research.
Okay, thank you very much. Kathy Hetley says, I'm wondering if you recommended telehealth for counseling in a men's shelter, counselor in one office and the client in another office, and do you need a telehealth consent?
So would the circumstance be that they're in the same building, they're in separate offices?
It sounds like they're in the same building
Right.
and separate offices.
I would say yes. I would still get the consent. I mean, I know it's not really the spirit of the law because you're still in the same building, but anytime we put information on the internet, there's that additional risk. And anytime we kind of can't see what folks are doing, we're going to need to benchmark those same expectations about, this is healthcare appointment, so on and so forth. In the beginning for telemental health, we almost always did these appointments where one person was in one clinic, the other person was in another clinic. It was always what we called supervised settings. So there was someone boots on the ground, a medical person in the next room, much like, might be in this circumstance. But we still got the consent, and I'd still do the emergency plan just because it's different than care as usual.
Okay, thank you. Brittany Webb asks, what have been some ways you have increased client engagement to do telehealth?
Sure. I mean, I think what I'm presuming we're talking about, and I don't want to be assumptuous, but what I'm presuming is like when folks aren't really sure they want to do this, or maybe it's just, they're not loving it, I think what I do, several things. One, I really do believe in that test call. I think that test call gets over some of those first, meeting jitters and helps folks kind of know what to expect and helps them be more at ease during the first therapy session. I like to slow things down and check in, like, how is this feeling? I really want to validate. If they don't like it, we can talk about that. And I really want to come at a place that's not defended, where they feel like they're offending me if they don't like telemental health. So it's certainly not the case. I've had one or two clients, over the years who just, it's not for them. I had one client very recently. He's very stable in his sobriety, got a lot of good years, has a lot of supports. He's going to his groups, virtually. And he just said, we're going to pick this back up when things settle down. And I thought that's totally valid. But, in terms of increasing, so it's like I try to be non-defensive and I try to not make folks feel forced in the modality. But in terms of increasing the engagement, I'm really just asking a lot more questions explicitly, because I don't feel that I can assume as much. I can't trust on my intuition, about what this movement meant or what, looking over here meant. I can't be assured that I'm seeing a tapping foot or a picked cuticle, so I'm just slowing down. I'm asking more questions. I really look, I think, a bit more Rogerian supportive therapist-y in my affect maybe than I would in other circumstances, but I really try to show up in a way that is emotive and warm. I remember when I took my first telemental health trainings, they said you should show 110% of your usual emotion, which I thought was the most insane thing I'd ever been told in a training. And now I will tell you, you should show 110% of your usual emotion, really making sure that your face is expressing. And if you're not sure about this, record yourself. It can be horrifying and informative in my case. Record yourself, see what you look like, when you say these things, because I think people are often surprised. When I had a postdoctoral training program in telehealth, and we would always record the trainees, and routinely every year, their first recording, they were really shocked by, because they were these warm, lovely people, and the recording, man, they look stone cold, so helping you to make sure you're emoting and showing up in that way, I think can help clinical engagement.
And just a tag along to that is that many of our providers don't have their facilities to provide context for them anymore. And so the context is the responsibility of you and the person that's on the phone.
Right. I think that's well said. Yeah.
One last question here from Vivian Long in Northeast Georgia.
Oh, wow.
She says, how would we be most effective running a crisis hotline 24/7 suicide ideation overdose side by side with a telehealth medicine platform?
Well, that's a great question. You know, I would not opine as to how like call triage works, and this would be just above my pay grade. I would think my first thought is I would look to how telephone-based models have done it, because in many ways, the addition of the video conferencing, like telephone triage for emergent cases is a well-established milieu, whereas video conferencing is not. But the reality is like, it's just a technological innovation. You know, we're just adding video, you know, to this interaction. We're not necessarily changing the clinical content. So my first thought would be, you know, for figuring out how you're going to triage those cases as they come in, and then, you know, ascertain whether you're setting emergency services or whether you're signing up for later care. Whatever the case would be, you know, we'd want to think about using a tool that has some capacity to modulate the waiting room, because what you wouldn't want is 100 people waiting in your waiting room. You know, I think there'd be huge liability issues, and most video conferencing products are not well established to do it. So my first thought would be that we'd want to look towards the telephone-based models and then figure how we're going to augment those calls with video as they kind of come up to their time in the queue. That's a really hard question. I hope that's some information.
I wanted to tell you, Sarah, that was one of the first questions that came in, and I thought it's a little hard. Let's warm up on these, and we'll get to that one.
It's a great one. What an important question. So yeah. I think my thought would be, you know, we'd lean into folks who've done it. You know, we won't reinvent the wheel, and we'd, you know, think about a product that doesn't queue people up, but just brings the video onto the call, you know, as they're having their evaluation.
Okay. We're right at 1 o'clock. There's a few more questions coming in, but then you're offering this wonderful series going forward. So for folks that have further interest, we can get you to sign up to those courses and they'll get that. And then the last thing is we have an evaluation we'd love people to fill in, and we'll make sure that that gets to your inbox. Jennifer, anything else?
Oh, yeah, and I just wanted to remind everyone that a recording and the slides will be available on our website later this afternoon. And then if you didn't catch the link to our survey, it's also in the chat box, but it will be in that same email. And then I just wanted to let everyone know that we'll have our next monthly webinar on May 27th, and the topic and those details are still to be determined, but that will also be on our website. And I just wanted to, you know, thank everyone for joining us today. Thank you, Sarah. This was great information. And thank you, David, for compiling all the wonderful questions that we got in.
Indeed. And thank you, Sarah and Jennifer.
Great. Well, thank you, and have a wonderful day.
Okay.